And I would like to start by saying thank you so much for inviting me, for having me here. It's now my second, or I think maybe my third time in Bangkok. So unfortunately, very short visit, but I'm looking forward to it. And then thank you for the invitation, and I hope that we can share some insights on what we do in South Africa in terms of the Phadiatop test, and maybe you can also use some of it here in Thailand. Without any further ado, I'm going to quickly take you through the agenda. So we're going to talk about allergy background and the terminology, because I think that's really, really important. When we talk about allergy, there's so many different terms being used, and I feel that in order to understand it properly, we need to clarify the terms being used in allergy. And then, of course, where to start. And allergy testing is like walking into a big shop full of sweets. You know, you don't know where to start. And they all look good. And then, of course, common allergens. And then lastly, I'm just going to take you over the result interpretation and what we think, or what I think, how you can do that. So let's start with revealing the secrets behind these allergy-like symptoms. And like I said, let's start with the basics first. So when we talk about allergy, it's important to understand that we talk about the immune system. It's a hypersensitivity reaction. It's a type 1 hypersensitivity reaction most of the time. It's therefore IgE mediated. But if the immune system is not involved, it cannot be called an allergy. And then you cannot test for it as an allergy either. The second important term is sensitization. Really, really important, and I'll explain a bit more about that in the upcoming slides. And then the last part you see there, these may also be cell-mediated. Yes, I think you might know that there's IgE receptors on the mast cell surfaces as well as on basophils. And these are then basophil-mediated reactions, although IgE can be involved as well. But sometimes we see direct stimulation of a basophil. So allergy is a worldwide problem. It's not just here. We see it in Africa. We see it all over the world. And we've seen an increase of around 25% in allergies worldwide. Although the impression is often that it's just a irritating little disease. You know, it's your eyes are watering, your nose is running a bit. But in fact, it can be life-threatening. And if you look at conditions such as asthma and anaphylaxis, these are very, very serious. In the end, allergies affect the quality of life of patients. And it certainly has a major impact on the health expenditure on any country and its systems as well. Unfortunately, allergy is often misdiagnosed, it's mismanaged, and because it's mismanaged, it's maltreated. So we're going to look a bit more into this. So why is allergy a growing disease? And first of all, it's a multifactorial disease. And these 4 points you see there, genetic constitution, allergen exposure, environmental factors, and lifestyle differences, are the most common topics to be discussed when we talk about the increase in allergies. Lifestyle differences and environmental factors such as pollution probably play the biggest role. I'm from Africa. And we've seen a lot of change there, rapid urbanization, people moving out of the remote areas into the cities. And here they're exposed to different allergens, not just inhalants, but also different foods. And you might be seeing the same thing over here. So the question is, why should allergy tests be done? Is it important? Can we not just accept that it's not the big issue? Can we not just accept what the patient is telling us? And the answer is not so simple. There are several points we need to consider. The first one is, we test because we want to provide relevant and effective therapy. And then, secondly, to identify these trigger allergens is really important. And there are 3 simple reasons for that. It can decrease symptoms, it can decrease the need for medication, and it can certainly decrease the risk for severe allergic reaction, especially in cases where patients know what they're allergic to. Something very common, let's say like shrimp allergy. If they know they're allergic to shrimp and they simply avoid it, the chances for severe reactions are severely decreased. Then, of course, when we treat allergies, most of it is symptomatic. The only disease-modifying therapy is immunotherapy or desensitization. But for this, we need to know exactly which allergens are triggering the allergy. And then lastly, but certainly just as important, we need to identify these patients who could actually be suffering from something else apart from allergies. Because this will prevent unnecessary treatment, for instance, with antihistamines. And we've seen that up to 65% of patients reporting signs or symptoms like rhinoconjunctivitis may actually be receiving antihistamines for all the wrong reasons. And then, of course, we also want to prevent unnecessary allergen avoidance, with, especially in children. Patients often assume that they know which allergens are causing the symptoms. And if you remove certain foods, let's say milk, for instance, that'll certainly have a major impact on the development of children. Animal removal might not sound very important, but if a child's got a pet in the house and that pet needs to be removed, it is traumatic for that child. It affects quality of life. It is not a nice thing. We can test for it. We can see from that whether it's actually necessary or not. So if you look at these symptoms, nasal congestion, itchy, watery eyes, wheezing, cough, skin symptoms, are these all attributed to allergy? And you can see in the first line there that 65% of patients diagnosed as having allergic rhinitis are prescribed antihistamines, and they might actually not need it. If we tested for it, the indication might have been totally different. When we talk about wheezing and coughing, 90% of children and 60% of adults suffering from asthma actually have an underlying allergy. In skin symptoms, it can be as high as 70% in infants and young children, and the cause will be an underlying allergy. So like I mentioned, we need to look at the terminology, and I think before we test, it's important that we understand these things. So the term allergy is very loosely applied to so many different reactions, and we need to distinguish between them. It's really important. First of all, you get real allergic reactions, and these are then mediated by the immune system. And like I said right in the beginning, if the immune system is not involved, it cannot be called an allergy. Then intolerance reactions. How many times do you hear patients and even doctors talking about intolerances and sensitivities and allergies, and it's not the same thing. With an intolerance, the immune system is not involved. And then there's other reactions, side effects of drugs. Some foods might contain histamine, for instance, in certain cheeses and red wine. So there you look at pharmacological reactions taking place and not a true allergy. So allergy tests can only be done for an immunologically mediated reaction. So allergen-specific IgE measures sensitization and not clinically relevant allergy. So you might say to me, but you thought that's why we're testing allergies, to diagnose an allergy. Well, yes, it's true, but I'm going to show you now exactly what does the term sensitization mean. And then lastly, important thing to consider, after testing, the results need to be correlated with the clinical findings. So For the purpose of today, you can split these adverse food reactions into toxic and non-toxic. And if you look at the non-toxic reactions, you'll find immediated versus non-IgE mediated. So things like intolerances fall under your non-IgE mediated reactions. And then there's immune mediated, and for the purpose of this talk, that's where we'll be focusing. So these can be split into your IgE mediated reactions and non-IgE mediated reactions. Now, unfortunately, there's another complication. Autoimmunity can also be brought into this equation when we talk about diseases like celiac disease. But like I said, for today, we're going to look at an IgE-mediated reaction and how do we actually test for it. So I just want to give you a brief overview of some examples of food intolerances, lactose, fructose intolerance. Excuse me. These are due to the inability or the insufficient ability to digest milk, or more specifically the sugars contained in the milk. But you can see that the symptoms can very easily be confused with those of allergy. But important, it's not an immunological reaction. And therefore the tests that you see there are not allergy tests. When you talk about gluten intolerance, yes, the water becomes a bit more murky because we're talking about gluten. And gluten, it's that fraction that causes delayed gut hypersensitivity, it causes damage in the gut, and it's a autoimmune disease where you talk about testing for a completely different antibody. So I'm not going to dwell further on that. I want to take you directly to the immunology of allergy. And you can see these can be split. This is the classical Jalen-Coombs classification of hypersensitivity reactions. You see type 1 to type 4. And for the purpose of today, we're going to look at the IgE-mediated reactions. And you might be able to see here that we're talking about mast cells. We're talking about IgE receptors on the mast cell. And for a type 1 hypersensitivity reaction or immediate hypersensitivity reaction, we need cross-binding of two IgE receptors on the cell surface of the mast cell. Once you have cross-binding, it will trigger the release of certain mediators such as tryptase and antihistamine. And as you know, antihistamine is the cytokine responsible for allergy symptoms. So just a brief overview of what happens when a patient or somebody encounters an allergen for the first time. So this allergen will move into the bloodstream, and yet will be encountering a cell called an antigen-presenting cell. This antigen-presenting cell will take this allergen, break it into small little pieces, and then it does exactly what the name says. It takes this little piece into a lymph node and it shows it to the immune system. It says, look what I found. And then the immune system needs to decide what's next. So here, this antigen-presenting cell will present the allergen to a T cell. The T cell will then transform into a T helper cell. And the T helper cell, through a process called class switching, will instruct the B cells to transform into a plasma cell. And as you know, plasma cells produce antibodies. And this plasma cell will then produce IgE antibodies. But it will also release certain mediators and certain cytokines like interleukin 4. Once you reach this point, the patient's being sensitized. And that's why I think this is such an important concept. When we test for sensitization, not clinical allergy. So once this has happened, these antibodies will move back into the peripheral system, where they will go and bind on the cell surface of a mast cell. And once that has happened, Once the patient encounters that same allergen for a second time, you'll get your cross-binding of the IgE receptors on the cell surface, and this whole process will start again. You get the release of mediators, such as your histamine, and this process will then run like that, instead of starting all over again. So why is it important to identify trigger allergens? Now, this is a very simple way to give you an idea what is happening. And I'll try and put it into a practical example. So a patient might be sensitized to allergen 1 and allergen 2. So let's say a child wakes up in the morning and is completely symptom-free, asymptomatic. Then the child goes and have breakfast, cereal with milk, still absolutely no problem. And then, of course, he goes and play outside, or mom says go and play with a dog, whatever the case might be. And then a short while later, this child comes back in, and his eyes are tearing, nose is running. What does mom say? Mom's going to say you're allergic to grass or the dog. And it's simply because a third allergen was introduced. The patient was asymptomatic, but the moment a third allergen was introduced, he started presenting with symptoms. So the purpose of allergy testing is to identify these triggers or these sensitizations to see which ones can we control or manage. That's why we're managing an allergy. So if you can decrease, let's say, allergen 1, that patient might have been exposed to house dust mites. If we can control the house dust mites on the bed he was sleeping, and you reduce this allergen load, allergen 2 and allergens 3 will now not push that patient over the symptom threshold anymore. And the patient will be asymptomatic. So therefore, identifying all the obvious allergens is not always enough. We need to test a bit further and to know exactly all the relevant allergens and why they're important, because by simply doing this, we push the patient below the symptom threshold again. And it's important to understand that up to 80% of allergic patients are multisensitized. In other words, they're allergic to more than one thing. And the average patient is sensitized to 3 or more allergens. So really, really important, not just to go on the word that the patient is telling you that they think or suspect they might be allergic to. This bottom section is just a quick recap to explain or to let you know that allergy testing can be done at any age. What you do need to keep in mind is the age of the patient. In other words, in very young children, especially in food allergies, even low levels of specific IgE can be really, really important and can induce symptoms. I'll show you that a little bit later. So why allergen avoidance? Well, simply because we can prevent allergies, especially if the antigen or the allergen is an obvious allergen, like in the case of seafood. But allergen avoidance also decrease and control a patient's symptoms. Like you've now seen, a patient may be sensitized but asymptomatic, but this patient may lose tolerance to these allergens if they're exposed to higher levels of this allergen. Then they lose the tolerance and they become symptomatic. So the question is, where do we start? Like I said, if you're standing there in front of a rack full of sweets, where do you start? Well, the most important part of an allergy diagnosis is a good history. In other words, the patient needs to give you a good history. You need to ask the right questions. We need to know which allergens were the patient exposed to. We need to know how long did the symptoms take before the patient became symptomatic. There's a lot of questions that we can ask a patient. It takes time. The second important thing to remember is that there are several different mechanisms of allergy. And of course, then you have several different testing methods as well. If you get a negative test on one specific mechanism, you've only excluded that one mechanism, and you need to consider other mechanisms depending on the history. And once again, I want to stress that laboratory tests should be correlated with the clinical findings. So in terms of the term sensitization, and like I mentioned, when we test sensitization. So if you get a positive blood test result, you did not diagnose an allergy. The patient is just sensitized. But if you have a history of a positive allergic reaction, especially if you identified the suspect allergen, plus a positive blood test, in other words, you indicated sensitization, then you've diagnosed an allergy. It's a very, very important concept. So this is where a test like the Phadiatop or the Phadiatop infant comes in. So it's a really good starting point. So just so that you understand that the word Phadiatop was derived from Phadia, differentiate, atopy. So then you might ask, now what's atopy? So atopy is the genetic predisposition that the patient has to develop specific Ig antibodies to normal allergens that most people do not react to. So as a consequence, these persons then develop your typical symptoms that we see with asthma, rhinoconjunctivitis, or eczema. So this is a blood test that was specifically designed to differentiate between an atopic and a non-atopic patient. And it's also a very, very good first step to rule in or to rule out allergy. Because it also contains different common inhalant allergens, it also serves as a fantastic screening test for inhalant allergies. And for that reason, we've included the Phadiatop test in our South African testing guidelines. But the same has happened in the rest of the region that I work in, for instance, in Kenya, Ghana, and Tanzania as well. So how was Phadiatop designed? So like I said, Phadia differentiate atopy. And is this atopy concept of genetic predisposition to produce Ig antibodies, the common environmental allergens that we used to develop this test. It uses a combination of different common inhalant allergens, and this was very specifically selected, and you'll see why. The point is that at least 90% of your patients will be correctly classified as being atopic and non-atopic, or an allergic patient versus a non-allergic patient. So you get two versions. There's a Phadiatop and Phadiatop infant. The Phadiatop is just a well-balanced mixture of these common inhalant allergens, and it covers different sources. So you'll see there's house dust mites, animal danders, cockroach, grass pollens, tree pollens, wheat pollens, and molds. When we talk about Phadiatop infant, we've added some foods, and specifically because children are exposed to foods earlier than inhalant allergens. The results usually get reported as either a positive or a negative, and in most instances you also get an actual value, so you can see how high or how low the result was. So a positive blood test will then indicate that this patient is probably sensitized to some of the inhalants in that mix, and a negative blood test will actually rule that out. So just to show you what we've seen in South Africa. So this is the Phadiatop screen, and this is the positivity rate that we've seen in the different regions in South Africa, because it's a very big country. The different regions have different sensitivities, different allergens. So you can see here that it varied between 45 to 50%, indicating to us that the doctors are using this correctly, and it served as a very, very good screen to rule in or to rule out allergy. So up to 55% of the suspected allergic patients or atopic patients could be ruled out using the Phadiatop test. The other 45%, of course, these need to be followed up. So I think this shows how effective this test is as a screening test. So when do we use Phadiatop or Phadiatop infant? Well, first of all, to rule in or to rule out allergy and to confirm atopy in a patient. And then, of course, in cases where food is involved as well, and also, patients keeping exotic pets, for example. Because this test also tests for cross-reactivity or cross-sensitization, it is designed that it will also pick up these patients. When is this test not indicated? If you have a very strong suspicion of the specific allergen, if this patient tells you, I react every time I eat strawberries, then there's no need to do a Phadiatop test. Then it's better to test directly for that specific allergen. And then, of course, patients that are non-atopic. In other words, and as an example, for instance, patients allergic to venom, to bee venoms, or to drugs. Those patients got an allergy to venom or an allergy to a drug, but they're not atopic. So I often get asked, what's in the Phadiatop? And actually, it's not needed to know the content of the Phadiatop, not the exact content. It's important to know it's a combination, of house dust mites, grass pollens, or different pollens, wheat, tree pollens as well, molds, cat and dog. And in the case of Phadiatop infant, there's also egg white, peanut, milk, and shrimp included. So I often get asked, why is the Phadiatop content, why isn't it a secret? It's not a secret. I can tell you exactly what's in there. But the problem is, we find that doctors then use it incorrectly. The idea is not to test a Phadiatop test and then test exactly what's in the Phadiatop test. The idea is to investigate which allergens are that specific patient reacting to in his environment. And that's what we need to do. So we need to follow up this test. You cannot stop if you find a positive Phadiatop or a Phadiatop infant test, because then you still have no idea what's going on with the patient. Another question, why should we use Phadiatop test? Why not the total IgE? Total IgE should give us the answer. And that's actually a very, very big mistake. Total IgE measures the total sum of all IgE in the blood, including irrelevant IgE. For instance, in the case of parasitic infections, you get the production of IgE. And the scary statistic here is that up to 50% of patients suffering from asthma will not have an increased total IgE. The other half, yes, they might have a total IgE, but you will miss half the patients. So Phadiatop measures allergen-specific IgE, not the other irrelevant IgE that we're not interested in. And therefore, it's a way, way better test to use than a total IgE. And that's why you find that up to 90% of your patients will be correctly classified. And due to the sensitivity of the test, which will, of course, confirm an allergy, and the specificity, which is designed to exclude an allergy, you can have confidence in this specific Phadiatop test. So this gives you a good indication as well. If you go in case history alone, less than 50% of patients will be classified correctly. If you add total IgE, yes, it adds a little bit, but not much. But if you take the case history, plus Phadiatop or Phadiatop infant, the blood test, that goes to more than 90%. Clearly, Phadiatop or Phadiatop infant is the way to go. If we split the two, you'll see that the sensitivity in both these assays are quite good. Specificity excellent. Phadiatop infant is, of course, slightly higher in sensitivity because it also includes foods. But you can see total IgE missed the bus completely. It's really irrelevant, it's the wrong test to use to test for allergy. So how should Phadiatop, or how do we use the Phadiatop test? Well, first of all, we're going to confirm or exclude allergy. So if you have a negative test result, that will indicate these symptoms are probably not caused by a specific IgE, and you need to go and look for other causes of the symptoms. If you do find a positive test result, in other words above 0.35 kilounits allergen per liter, the patient is probably suffering from a specific IgE or a specific IgE-mediated allergy. And in this case, you need to follow up and test for the whole allergens to identify the provoking allergen. So the question is this test then relevant to cover all important allergens even over here? And the answer is yes. And the most important part is this middle part here, that this test uses cross-sensitization or cross-reactivity, as well as co-sensitization in patients. And this is the very well-known allergy or atopic concept that we used for this test. So I can just briefly mention to you that because we're in South Africa, we thought we're different. So we should have our own Phadiatop test. Now you get different versions of the Phadiatop test. So we went to Phadia and said, guys, sorry, but we're special. We want our own test. And we even know what we want in there. So after much protest, they actually developed this test for us. And after lots of money, blood, sweat, and tears, we had to can the entire project. This test failed horribly. It didn't work at all. And the question is, why didn't it work? Because we included the allergens that we believed are the most important ones. But what we did unknowingly, we destroyed this concept of cross-sensitization, or cross-reactivity. So the allergens that we asked to be in there simply did not pick up all this cross-reactivity that we see with grass, for instance, and house dust mites. So yeah, we had to admit that the test did not work for us, and we went back to the original Phadiatop test. So can it be used as an atopy test in children? Yes, absolutely. Just keep in mind that at a very young age, children are often not exposed to so many inhalant allergens. So you can expect the sensitivity of the test to increase with an increasing age of the patient. And of course, in the case of children, it's a much better test to use because of the foods that are included. So what do we do with this positive result? Why should mixes be broken down? The answer is pretty simple. If you do not break them down, that will result in suboptimal management of the patient, because the patient cannot be advised on what to avoid or how to handle or manage the allergy. And this is all very important, because if you do not break down the test into the individual allergens, the patient still doesn't know what causes the allergy. And these allergens then cannot be controlled, it cannot be avoided. In the case of foods, they don't know which foods to avoid, and the patient might actually be avoiding these foods unnecessarily. If you do decide to do immunotherapy, you cannot decide immunotherapy if you don't know which allergens are involved. And very important, if you do want to follow up on cross-reactivity, you cannot do so. If you do decide to do that, you can test for things like cross-reactive carbohydrate derivatives, which are often the cause of cross-reactivity in terms of pollens and foods. So ask yourself, what does a positive Phadiatop or the infant alone going to tell you? What advice you can give the patient, if you did not do the breakdown of this test. And this is why I think, what is the point of allergy testing? Well, the first point is about the patient, to improve the quality of life and the patient well-being. And the second point is for you, the doctor, because you want to gain as much information as possible about this allergic condition and the different sensitizations, so you can make informed decisions and manage this patient's allergy much, much better. So I'm quickly going to talk about common allergens, and I'm referring here to complete extracts. In other words, not components, it's a complete extract. And I've divided it into 3 different groups. The first one is children under the age of 4. And you'll see the most common food allergens here. No surprises there. Colorants and preservatives obviously play a big role. That's not something we can test for in terms of specific IgE testing. That is very often a basophil-mediated reaction, so you need to do CAS testing for that. In terms of inhalants, you can see not often a problem before 2 years of age, but certain indoor allergens can play a role. In older children, no change in foods, but certainly the inhalants become a bigger issue there. And then in adults, the foods stay the same in terms of the most basic ones, but we can add shellfish, cheese, citrus and tomato, for instance. And the inhalant allergens will then remain the same. Inhalant allergens worldwide are basically the same. There's no big difference in them. So this is the last part, just the interpretation of the test. So just the basics. Please remember this. When we test for specific IgE, we measure sensitization, not necessarily clinically relevant allergy. And also remember that even low levels of specific IgE should be interpreted with caution. It can also cause a severe allergic reaction, and we need to consider the patient's age, and I'll show you an example now. So the common cutoff is 0.35, but we can measure down to 0.1. But neither of these two has ever been claimed to be a clinical cutoff. It was a technical cutoff. When the first tests were developed, the first RAS test, the technology was simply not able to measure lower than 0.35, and that's where the cutoff came from. Unfortunately, this cutoff is often being used as a clinical cutoff. And with a result interpretation of positive, that gives a very negative connotation to it. But we need to interpret it, and we need to make sure that we correlate these clinical findings with the level of suspicion of allergy as well as the relevant specific allergen. We often hear that the test was false positive. The test is not false positive. If we measure something, there's definitely sensitization, but it's asymptomatic sensitization. So in terms of Phadiatop, I just want you to be aware that you can end up with a positive result without anything being positive when you pick it up. And this we see in low-level sensitization. In other words, if you have a lot of allergens which are just below or just close to the cutoff value of 0.35, these can add up to just push the result over the 0.35 cutoff. And if you then go and test for the individual allergens, you'll find that they're negative. And the opposite can also happen, that you have a negative result, but if you do decide to do the specific allergens, you pick up something. And this is often the case in monosensitized patients, because remember, the Phadiatop, just like any other allergy mix, has a limited number of binding sites due to all the different allergens included in the mix. When we test for a specific allergen, there's way more binding sites, and the sensitivity is then higher than just with a screening test. So I mentioned that we need to consider things like age in a patient. So this graph will show you the relation between IgE antibody concentration and the probability that the patient will react at a certain level. And you can see the higher you go, the higher the Ig antibody concentration, the higher the probability that this patient will be symptomatic. Of course, this graph can move to the left or to the right, depending on factors such as age. And I just wanted to show this to you when we talk about an egg allergy. So here you can see the classical cutoff of 0.35, and you'll find that in older children, the chances of reacting is very, very slim. But if we extrapolate this data, and you go look at the 0.1 cutoff, then you find a different story. So there you might find that in very young children, for instance, in 6-month-old children, there's a 22 to 25% chance that this patient will react at levels that low. But that's up to you as the clinician to decide whether it's relevant or not. This is the original class system. You might be familiar with it. I'm not a big fan of it, but I know it's being used everywhere. I prefer to look at it this way, where we can actually look at the value obtained, the quantitative result. It gives a bit of an explanation about the Ig antibody level. And you can see the higher this Ig antibody level, the higher the symptom relation becomes. So I prefer to use this. I think it's a lot more useful than just a class system. And with that, I say thank you so much, and thanks for the opportunity.